good afternoon. At the outset, I like to congratulate Dr. Jyotidev and his team for this excellent opportunity for us to meet the experts and also know the new things in diabetes. And I'm happy that I am also part of this big event. As a pediatrician with special interest in nutrition and child development, two things have fascinated me. One is the first 1,000 golden days in an individual's life, 270 days in utero, and 730 days made up by the first 2 years of life, when tremendous things happen in growth, mental development, and emotional well-being. And the second, of course, is the fetal programming, the EARNEST, that is the European Early Nutrition Programming project. In fact, there is a paradox, and there is fetal programming which is happening because of excess fuel in utero, and coming out also there is excess fuel, and they are programmed in a different way. The second, of course, is the fuel deficiency in utero and the Barker hypothesis and a different programming altogether. And then the mismatch, which is happening especially in Kerala or perhaps in India also, that is the in utero deficiency and postnatally the fuel excess. And we are very fortunate to have the oration on fetal programming and type 2 diabetes by none other than Dr. Chittaranjan S. Yajnik, whom we always look upon as an original researcher who has done tremendous contribution in this field. He was trained in Mumbai and Oxford and is working now in the KEM Diabetology Center, Pune, and he has original publications and lot of original work. In fact, I had the good fortune to listen to him during the national conference of IAP a couple of years ago, and I also confess that I also have the YY paradox, that photograph of Dr. Yajnik projecting him as the thin, fat Indian. So over to Dr. Yajnik for this oration.
Okay, good afternoon, everybody. Start by thanking Dr. Jyotidev for inviting me and for Dr. Elizabeth to introduce me. I'm going to restrict myself to some of the recent findings we have on 18-year follow-up in the birth cohort, which we set up in 1993, and I think is going to write some new chapters in diabetes world. And that is the evolution of diabetes-related phenotypes across the life course. I dedicate this to the father of this field, that's Dr. David Barker, with whom I have worked since 1991, and he passed away in 2013. In the textbooks, diabetes is described as a condition which has genetic susceptibility, and then it is precipitated by the obesogenic lifestyle factors. Usually, we think that these obesogenic factors are present in adult life. Probably whole morning people have told you that diabetes can be prevented by starving the adults and probably making them work a little bit more. That's the current fashion in the world. I'm going to try and tell you that these factors, if they happen in the young girls, will actually increase the diabetes in the next generation. So the solution is very different. So this idea that eat less and walk more and diabetes will go away is a very misleading idea, because it's treating the condition in those which have already occurred. To prevent diabetes, and especially to prevent in the intergenerational manner, we will have to probably make the young girls eat more and probably walk less, especially if they are working very heavily in the fields. I don't know whether you've seen this website. It's called worldmapper.org, and it shows what are called cartograms. Cartogram is a map where size of the country is proportional to the burden of the disease. It's not the geographical area of the country, it's a burden of a condition. And if you look this cartogram of diabetes, then you can see India is a very fat country. And given that we equate diabetes with overnutrition, we would just think that India would also come out as a fat country in the overnutrition cartogram. However, if you look at the undernutrition cartogram of the world, then India is even fatter country. There is no other country which is as fat as India. And this is undernutrition under 5 years of age. It includes low birth weight, which is intrauterine undernutrition, and under 5 undernutrition, which our chairman is an expert on. Low BMI in children under 5 years of age. So there must be some connection between this, and this was not apparent to us, it was apparent to David Barker. So an Englishman had to come and tell us this. And that also tells us that life course nutritional history is very important, and that's what the chairman again referred to, that overfeeding the undernourished children might produce more problem. Overfeeding the babies in utero, as in diabetic pregnancies, might produce more problem. And that's why a life course history of nutrition is very important. And this was quite adequately actually expressed by a Danish philosopher. Danish philosopher Søren Kierkegaard said life can be best understood if you look backwards, which we all understand. Many things in our life, if we look back, then we understand them much better. And that's the philosophy for research in my unit, and that's what David Barker did. He studied adults and then showed that the risk of diabetes was high if they were born underweight, which means they had a lower birth weight. Lower birth weight increased risk of diabetes in a large cohort of people in England who were born in 1930s. And this finding has been repeated across the world in various countries, and many studies in India. So low birth weight is a very potent risk factor for future diabetes. And those of you who attended Dr. Mohan's diabetes update last week in Chennai, Professor Yu from Harvard, in a very large study in US, which was published just 2 weeks ago in BMJ, showed that low birth weight in the US contributed 41% to the population attributable risk of diabetes. So it's a worldwide phenomenon. And my unit has worked in this since last 25-30 years. And this graph shows you the life course sort of studies which we have done. Is there a pointer? Yeah, there is one. So what it shows is that we started studies in the adults and then realized that studies in adults are not adequate. So we went back to children, then we went back to very young children, then we went to pregnancy, and then we started studies in pre-pregnant condition. This is one of the few diabetes units anywhere in the world which can boast of studies across the life course of diabetes evolution. And this is the flagship study in my unit. It's called Pinay Maternal Nutrition Study. We studied in 1993 over 2,600 women in 6 villages near Pune when they were married but not pregnant, in the hope that they will become pregnant during our study period. So out of these 2,500 women, 814 became pregnant in these 3 years of the study. We studied their nutrition very intensively, physical activity very intensively, their metabolism, glucose tolerance test, father's measurements, and fetal growth by ultrasound. It was the first prospective large study of fetal growth in India. Then over 770 normal singleton children were born, and we followed them every 6 months since then till last year, which is 18 years, for their growth. And every 6 years we study the children and parents for their growth, their body composition, their metabolic risk, cardiovascular risk, neurocognitive development, and now we have included genetic and epigenetic studies. It's one of the best studies anywhere in the world, and you can see we have more than 95% follow-up even at 18 years of follow-up. In Western world, they are very happy if they have a 50% follow-up by 5 years of age. At 18 years, we have 95% follow-up. And this study has actually given us a lot of interesting information. We have blood samples and DNA on all these mothers from during pregnancy, on the children at 6 years, 12 years and 18 years of age, and now we will continue to have it. So in other words, we have one of the best biobanks of blood samples on these children and their parents. What we have shown in this study is that the mothers, these rural mothers, were on average 42 kg to begin their pregnancy, with a body mass index of 18.1, so clearly very undernourished. The babies were 2.7 kg on average. And we compared these babies with babies born in the England in David Barker's unit. And what we found was that the English babies were on average 3.5 kg, 800 grams heavier than the Indian babies. But when we measured their body fat, so when we compared the body fat in these newborn children, the 800 gram lighter, lower birth weight Indian children, it's there, had a higher body fat compared to the English children. And this is a first description of a thin fat Indian baby. Chairman described my picture in Lancet, which I projected 10 years ago as a thin fat Indian. You can see me how thin I am, but my body fat was more than twice my English friend who had a similar BMI. Here we showed that a newborn Indian baby who is 800 grams lighter than an English baby has more body fat, and we could show it even on a whole body MRI, that the intra-abdominal fat and the subcutaneous fat in the abdomen was higher in the Indian babies compared to the English babies. So they look thin, but they are fat. And if you go to their cord blood, they had higher cord leptin concentrations, higher cord insulin concentrations, and lower adiponectin concentrations. 3 major risk factors for future diabetes present at birth in the cord blood. So that was a very dramatic finding. And what we then showed was that the baby's size was more related to the micronutrient-rich food consumption in this village population. The frequency of consumption of green leafy vegetables, milk and fruits, they all had an effect to improve the fetal growth. And finally we showed that low maternal B12 and high homocysteine concentrations in pregnancy predicted intrauterine growth retardation, which is poor fetal growth. So maternal B12 deficiency and high homocysteine were predictors of intrauterine growth retardation. In number of other studies, folate deficiency has been shown to be a problem, and in some other studies, vitamin B6 deficiency has shown to be a problem. All of them increase homocysteine concentrations. So we'll come to the long-term follow-up of these babies and what we found at 18 years of age, our latest follow-up. At 18 years of age, we were able to study, as I said, more than 95% of these children. And to our amazement, when we did the glucose tolerance test, used the ADA criteria for IFG, IGT and diabetes, one girl was non-diabetic. And we know that she has a MODY, the maturity onset diabetes of the young. 18.4% children had IFG, high fasting glucose. 10% had high 2-hour glucose, so IGT. So a total of 28.7% of 18-year-old children with an average BMI of 19 had pre-diabetes by the American Diabetic Association criteria. This is one of the highest anywhere in the world. And in boys, the prevalence was twice as much as the girls. So boys had 37% pre-diabetes while girls had 18.5% pre-diabetes. This is very high in a thin rural Indian population. So what I have done now is that we have analyzed the phenotype at 18 years of age, and we have used 2 markers. One is a glucose tolerance and other one is an MRI measured distribution of body fat or fat in the abdomen. So that's central adiposity. We are then able to relate this phenotype at 18 years with what happened during the life course of that child. So when the parents were still, or mother was still not pregnant, we have that information. What was mother's condition in pregnancy? What was baby's growth? And what was baby's growth in childhood? So all this information is available with us. And then we can relate this phenotype with a whole lot of cardiovascular risk factors which we have measured at 18 years. So this is called a life course analysis. So you study people serially and you can define a phenotype in the adult life, but then you are able to relate it to a whole lot of measurements which you have done in early life, and this is what I said was looking backwards in the life. So at 18 years, when we measured these children, their average weight was 50 kg and their body mass index was 19 or so. And there was no difference in the BMI of children who had high glucose as opposed to those who had normal glucose. So they did not have higher body mass index, but they had higher waist circumference and they had higher MRI measured subcutaneous fat in the abdomen. Other components of metabolic syndrome were absent in the sense that they had similar concentrations in the 2 groups. When we went to these children's measurements in the previous measurements, we found that at 12 years, those children who had higher glucose at 18 years, they had higher glucose at 12 years of age. They had higher glucose at 6 years of age. And rather than insulin resistance measured by HOMA, they had lower disposition index, which is a measure of beta cell function in relation to the insulin resistance. So high glucose at 18 years is a reflection of high glucose from 6 years of age when we first measured it, and is a reflection of poor beta cell function from very early life. When we measured their size at birth, or that data we have, we did not find any association, but the high glucose children were born 3 days earlier, so they were born 3 days premature. And when we looked at a whole lot of mothers' characteristics in pregnancy, we found that mothers of high glucose children had lower triglyceride levels in the blood, indicating that they were undernourished. So these children had mothers who had an average BMI of 18.1. They had lower triglycerides. These children were born 3 days younger, and they had very high glucose, which was high from 6 years of age, because of poor beta cell function. What we are seeing is an intrauterine programming of beta cell dysfunction, which has been present from very early age and has manifested as ADA-defined prediabetes at 18 years of age. This is world's first description of prediabetes in very young based on their findings from before they were conceived. And this is how the association looks. So those who had lower gestation period in utero, the percentage of people with hypoglycemia is high, and those whose mothers had higher triglycerides, their children had lower prevalence of hypoglycemia. Then we have data on the parents. So parents were measured many times, but this is data when children were 12-year-old. So when parents were 38 and 33 years old, fathers and mothers, they also had very high prevalence of diabetes and prediabetes, especially prediabetes. And when we look at the characteristics of these parents, what we find is they have characteristics of type 2 diabetes in thin or lean type 2 diabetes. In other words, type 2 diabetes in these populations starts as beta cell defect very early in life. They do not have obesity manifested by high BMI, but they had central obesity and they had high subcutaneous fat on MRI. This is a very interesting picture, and for the first time tells us that how people come to this high glucose during their early and late adult phase, starting from what has been happening to them from before they were conceived. This is the abdominal fat measurements which we did with MRI, and using standard techniques we measured the subcutaneous and the visceral fat. And again, interestingly, now we are able to say that central adiposity at 18 years is related to so many things in the early life. So at 18 years we found that subcutaneous fat was related to a whole lot of cardiovascular risk factors. This is very different than what you find in adults, where visceral fat is associated with higher this thing. So during the evolution of phenotype along the life course, it's this subcutaneous fat which is a risk factor for cardiovascular risk in future life. And I think later on you deposit more visceral fat as you go on putting weight, and that manifests as the association. Again, this is world's first description. Then at birth, higher weight, higher head circumference and higher skin folds predicted higher subcutaneous fat at 18 years. That's what fuel mediated teratogenesis the chairman was referring to. And then during pregnancy, children who are having higher subcutaneous fat at 18 years, their mothers had a low vitamin D, low vitamin B12 and high folate concentrations. And their mothers had lower physical activity during pregnancy. So mothers who were deficient in D and B12, high in folate and were sedentary, their children had higher subcutaneous fat at 18 years and higher cardiovascular risk. And then intergenerationally, parents with higher BMI actually produced children which had higher subcutaneous fat. Again, this is a very revealing story, that your subcutaneous adiposity at 18 years is linked to your mother's nutrition in pregnancy, indicating that a micronutrient deficiency of vitamin D and B12 and excess folate, which we give quite a lot to these pregnant women because of the National Anemia Prophylaxis Program or to prevent neural tube defects, that seems to produce this abnormality. So this is world's first life course description of glucose intolerance in the young. High prevalence of prediabetes in young non-obese rural Indians. This is related to low beta cell function starting from very early childhood. Early life predictors are suggestive of maternal undernutrition in pregnancy. High subcutaneous abdominal fat predisposes to these abnormalities at 18 years of age. And this supports David Barker's thrifty phenotype idea, or an idea which I started my career with 30 years, which is called malnutrition-related diabetes. And future prevention trials should be intergenerational and address the susceptibility rather than precipitating factors, which is what you have heard all through the morning, that you will be able to prevent diabetes by reducing obesity, by starving people and making them walk more. If you were to really prevent it intergenerationally, then you need to do something very different with the young girls. So this is a cartoon I have drawn last year in scientific journals, that in addition to genetic susceptibility and later on lifestyle factors in the life, there is a very important susceptibility factor which is epigenetics. I'm not going to go into details of this new branch of medicine, but it involves a series of chemical modifications to DNA and other intricate molecules like miRNA or histone modification, which changes the function of the genes and how they are expressed. And this is very seriously affected by maternal nutrition, maternal stress, maternal physical activity, and maternal metabolism. This is the most exciting new branch in medicine, which tells you for the first time that susceptibility is not non-modifiable. It's not only genetic. It's modifiable, it's epigenetic, and therefore we need to concentrate on this modifiable susceptibility determination rather than concentrate only on modifying the precipitating risk factors. I don't know how many of you know of these two interesting phenomena. One is called elephant in the room. So this lady is sitting here reading something and she is completely ignoring this big animal in the room called elephant. And that's the usual blindness or selective blindness that we have. And we have completely forgotten about undernutrition in our country as contributing to future risk of metabolic and non-communicable diseases. And my usual experience over the last 25 years is everyone is very excited by diabetes prevention trials because everyone thinks we can do something today. We try to behave like this ostrich by putting your head under the sand. So to me, these two major issues in scientific strategies, elephant in the room and burying your head in the sand, actually has caused a lot of damage to our understanding of how to prevent diabetes. So I'm going to say now thank you and acknowledge massive work done by my many colleagues over the last 25 years. Participants who have followed up with us, as I said, more than 95% follow up over 25 years, and funding which has come from various organizations, mainly international, largely because they appreciate this work more than the local bodies. So thank you very much.
Thank you, Professor Yajnik, for that exciting lecture that you have given. Actually, we are sitting on a volcano, we understand. Fat India when compared to undernutrition scenario, fat in India because of the lifestyle diseases scenario, and also micronutrient deficiencies, which is adding on to the problem, and also taking us through your wonderful study on the life course analysis, epigenetics, and also the transgenerational effects. I think due to lack of further time and being customary that there are no questions are allowed for oration, we close the session and let us give Professor a big hand.